Good afternoon, everyone. It's 12 o'clock, so we're going to get started. And welcome to our cardio webinar, Heart Failure Risk Management, What to Know, What to Do. I'm Dr. Michael Constant, the Principal Investigator of the Ohio Cardiovascular and Diabetes Health Collaborative, also known as Cardio, and I'm joined by Dr. Sherry Boland, the Co-Principal Investigator of Cardio. Founded in 2017, Cardio's mission is to improve cardiovascular and diabetes health outcomes and eliminate disparities in Ohio's Medicaid population. Cardio brings together Ohio's 7 medical schools to identify, produce, and disseminate evidence-based cardiovascular and diabetes best practices to primary care teams. To learn more about the collaborative and to access our online repository of best practices, please visit our website, cardio.org. I would like to acknowledge and to thank our sponsor, the Ohio Department of Medicaid, and our administrative partner, the Ohio Colleges of Medicine Government Resource Center. I would also like to recognize the partnership of Ohio's 7 medical schools who contribute to make the Cardio Collaborative a success. Dr. Boland will now provide some logistics regarding today's webinar.
Great, thanks, Mike. Good afternoon, everyone. Just some brief logistics to please make sure your Zoom display name has your first and last name so we can see who's here for attendance and CME. If you're joining as a group, to please use the chat feature to record your names and emails of the attendees that are with you in the group. If you have questions, which we hope you do, we'll ask you to use the Q&A feature to submit questions at any point during the webinar, and we will answer those during the Q&A portion of the webinar. And then just be aware there will be a post-webinar evaluation survey that we'd love to hear your feedback to learn about what went well and what you'd like improvements for next time. Just letting you know that none of the speakers and none of the planning committee had any disclosures. And if you would like CME, there is CME for this. You do have to be registered. So if you haven't registered, just you can use the QR code here on the slide to register, and then you'll be able to click whether you're interested in CME, so we can send you a evaluation from myevaluations.com next week. And if you don't receive that and you have any questions about CME, just contact Kathy Sullivan. And with that, I'm going to introduce Dr. Amy Zack, who will be helping moderate the session and introduce our speaker. And Amy Zack is a family medicine physician and vice chair of education at the Cleveland Clinic and faculty at Case Western Reserve University School of Medicine. Dr. Zack serves as the head of education dissemination for Cardio. So delighted to have her moderate and introduce our wonderful speaker today.
Thanks so much, Sherry, and I'd like to welcome everybody to our webinar today. I have the pleasure of introducing our speaker, Dr. Mark Dunlap, who is the immediate past director of the heart failure program for the MetroHealth system in Cleveland, Ohio. He's a professor of medicine, physiology, and biophysics at Case Western Reserve University. He received his MD from the University of Tennessee College of Medicine and completed his training at the Medical College of Virginia. Dr. Dunlap was recruited to Metro back in 2006 to develop a heart failure program. Since that time, his multidisciplinary team has worked towards a goal of guideline-directed care for all patients with heart failure, avoiding hospitalizations and maximizing clinical outcomes. Dr. Dunlap has served as investigator, steering committee member, and endpoint committee members for numerous clinical trials designed to test new therapies for heart failure management. Additionally, he has published over 100 articles related to heart failure. So today we welcome Dr. Dunlap to speak to all of us about heart failure risk management, what to know and what to do.
Thank you, Amy, and thanks for the invitation to you and Sherry and the others that chose this topic and me as a speaker. I see in the pre-registration that there are a fair number of physicians and nurses, but there are also other people involved in other aspects of healthcare. What I've done with Sherry's and Amy's advice is to gear this towards a very general talk about especially the risks of development of heart failure. This is not intended to be a comprehensive talk about treatment, but we will talk some about actual treatment of heart failure as well. So with that, I have no conflicts of interest. These are the objectives for today: to screen and identify those at risk for heart failure, to understand the current disparities in risk assessment and management, to evaluate patients who may have suspected heart failure, and to talk briefly about the key therapies that we use in the management of patients with heart failure. So I asked this question to start our talk, just to get sort of people speaking. And what do these people all have in common? You see the list up there, the two columns. And so think about, let's see, they all, A, were born in Ohio, B, are dead, C, had wives named Betsy, D, had heart failure, or E, both B and D. Now, we don't have an actual audience response system, but if you were thinking that they, first of all, were dead and they all had heart failure, you would be correct, and that is choice E. A lot of famous people had heart failure, had and have heart failure, very common disease. So by way of that overview about the incidence and prevalence of heart failure, currently about 6.5 million men and women have heart failure. There's somewhere around 1 million new heart failure cases annually. Interestingly, as opposed to virtually every other diagnosis within cardiovascular medicine, the prevalence of heart failure is projected to increase by 46% by 2030, resulting in greater than 8 million people with this condition. The biggest risk factor for the development of heart failure is uncontrolled hypertension. And I'm going to be coming back to this importance of hypertension a couple times during the next 35 minutes or so. There's a large impact on healthcare resources, over 1 million hospitalizations every year. It's the #1 cause of hospitalization in the elderly population. And it's an expensive proposition, with over $30 billion a year for this diagnosis alone, and this is projected to increase to more than double that. The epidemiology, there's been this increase in heart failure-related deaths over the past, actually about 30 years, while there's been a decrease, as I mentioned, in other diagnoses. Heart failure has increased. And this has led to an increasing prevalence of heart failure that there actually is, is responsible for this increase over the next 10 years or so. And the main drivers of that projected increase are, one, the fact that heart failure patients are not dying nowadays like they used to. They're still dying, but not like they used to. And two, the aging of the population. I'll talk in more detail about that. There are racial and ethnic disparities in death from heart failure. We'll talk about some of these disparities. And it suggests that not only our treatment, but potentially our approaches to healthcare policy changes might be in order to address some of these disparities. These data from the Framingham Heart Study I think are very important to understanding our risk for developing heart failure. And what they show is that after the age of 40, we all have a 20% lifetime risk for the development of heart failure. Now, that 80-year-old man has a much more rapid chance of developing heart failure in his lifetime, whereas that 40-year-old woman has a much slower trajectory, but both carry that approximately 1 in 5 or 20% lifetime risk for the development of heart failure. This is a condition primarily of the older patient population. It's not that we don't see younger patients with heart failure, but the most common reasons, especially those that are fueled by hypertension and cardiovascular disease, we see in the older patient population, reaching a prevalence of approximately 14% in the older elderly patient population. These are some data that separate out both the gender-based differences as well as by race and ethnicity. You see that Black males have the highest, and this is measured in first acute heart failure episode, the highest risk at all ages, outstripping all the other subgroups here. Second, and coming in second, in this unfortunate race is Black females. But you can see among all these subgroups that by the time that we reach the 70s and then even more so in the 80s, it tends to be very high, as I mentioned, because of the risk factors that drive this disease. These data also are from Framingham and illustrate some important sex-related differences between how men and women develop heart failure. This shows in pie charts for men and women the attributable risks for the development of heart failure. What I'd like to draw your attention to, the fact is, first of all, that hypertension looms large for both women and men. But that risk is significantly higher for women. In other words, a woman can get to her heart failure just by having hypertension alone. Whereas in men, what's more common is the development of atherosclerotic vascular disease, especially with myocardial infarction, contributing to the development of his heart failure. But again, pointing that hypertension is important for both men and women. As I mentioned, the risk is higher in African Americans, approximately 50% higher incidence. Heart failure occurs at an earlier age with more left ventricular dysfunction. In this patient population, there's more hypertension, diabetes, obesity that contributes to the heart failure, but there's also non-ischemic causes of heart failure in this patient population. These patients tend to have worse symptomatology measured by NYHA functional class, as well as higher morbidity, at least as measured by hospitalizations. I mentioned that heart failure is an expensive proposition, and these expenses also are to increase. And if you compare on this graph, the increases in expenditures for diabetes, cancer, and myocardial infarction, you can see that expenses for heart failure outstrip all of these other causes with major healthcare resource utilization. So when we talk about the causes of heart failure, the risk factors are very, very important, especially hypertension, as I mentioned, but also obesity, diabetes, and the development of atherosclerotic cardiovascular disease. Now, all of these are important for the development of ischemic heart disease and myocardial infarction. And that, as I mentioned, especially in men, is often the road on the path to development of heart failure. However, they also contribute to non-ischemic causes of heart failure, whether that's through chemotherapy, whether it's through the sole hypertension itself, contributing to worsening risk of heart failure with myocarditis or pericardial cardiomyopathy. These risk factors can impact the development of both ischemic and non-ischemic causes of heart failure. Now, we all have been counseled on the benefits of lowering blood pressure in terms of reducing strokes and myocardial infarction. What I'd like to point out is that the biggest bang for the blood pressure reduction buck is actually developing the risk of heart failure, here shown as a 50% reduction in the likelihood of developing heart failure when blood pressure is lowered appropriately. So yes, and this is not to say that lowering the likelihood of stroke or MI is not important. It's just that heart failure is really the outcome that we get, like I say, this biggest bang for the buck. I mentioned the racial disparities and risks for development of heart failure. Among Blacks, a greater proportion of heart failure risk is actually attributable to modifiable risk factors. So especially high systolic blood pressures, but also elevated fasting glucose, development of coronary disease, left ventricular hypertrophy, as well as smoking. And left ventricular hypertrophy is threefold more prevalent in Blacks than it is in whites. Now, Hispanics also carry predominance of heart failure risk factors, and we're increasingly looking at the importance of this population for the development of heart failure. So women, compared to men, women tend to have more preserved left ventricular function in the development of heart failure, so-called HFpEF, heart failure with preserved ejection fraction. The onset tends to be at older ages, but then women have this catch-up phenomenon that is as prevalent in the older patient population. And the greater prevalence of hypertension, obesity, and anemia in terms of these as risk factors for the development of heart failure. Mortality, also we can break down the mortality risk by both etiology and gender. Shown on this graph is the highest likelihood for mortality risk is among males with an ischemic etiology for their heart failure. The lowest risk is are females with non-ischemic cardiomyopathy. I would like to point out that overall, females actually have a lower risk for mortality than do their male counterparts. However, the addition of ischemic disease in both men and women worsen the prognosis. Now, we know a fair amount about the difference, some gender differences in heart failure, mostly from a clinical perspective, some of which I've already alluded to. What is a very rapidly developing area of research, and that is the different genes among the prevalence of genes in men versus women that are responsible for these gender differences. So, as I mentioned, in terms of etiology, the relative importance of hypertension among women, shown on the left here, versus ischemic coronary disease in men. In women, the ejection fraction more often tends to be preserved following, as opposed to men, where men have disproportionately lower ejection fraction, lower levels or limited ejection fraction. Diagnosis, there's a lot that has been made out of using BNP levels, the B-type natriuretic peptide in terms of both the predictive value and development heart failure, as well as the severity of heart failure. Turns out most of that research has been done in men. And so we know more about that in men. In women, more often the diagnosis is made following an acute decompensated episode. Interesting, there have been studies about management of women with heart failure by male versus female physicians. And it turns out we male physicians are not as good in treating our female patients with heart failure compared with our female colleagues that tend to have better outcomes among their female patients. So when to suspect heart failure? Most of you are more on the front lines in terms of patients with risk factors than we in heart failure programs are. And so the issue of when do you suspect heart failure in patients who present with varying symptoms? Well, what are these symptoms? The most common is unexplained dyspnea. This is not the only cause of heart failure is not the only cause of unexplained dyspnea, of course, but it is a very frequent symptom and the basis of a lot of referral to heart failure programs with patients whose dyspnea is not due to any other at least easily found diagnosis. Those patients with a history of hypertension suspect heart failure. Those patients who have had a history of coronary artery disease, they're going to tend to be more men, but certainly women, and with ischemic heart disease, as I mentioned, with unexplained dyspnea, that it's very possibly heart failure. Those patients in whom you see signs of volume overload on physical examination, looking at the jugular venous pressure, we teach everybody who comes to our program, our trainees, fellows, residents, medical students, to carefully look at the jugular venous vessels, because the jugular veins, because that is actually our most sensitive indicator of volume status. But certainly edema. Now, we get sent a lot of patients who have unexplained edema. There are lots of things that can cause edema. One of the things I often do with these patients is, are they on a calcium channel blocker? And if they are, first stop the calcium channel blocker as a potential cause of their edema. But certainly it can be a symptom of volume overload. So the presence of elevated B-type natriuretic peptide. I will comment that BNP levels are lower in obese patients. We tend to use about a factor of 2 in obese compared to non-obese patients. That, in other words, it's only half as high in obese patients. So in an obese patient, we use a factor of 2. Although this diagram is somewhat dated, I like pointing out that what we're generally talking about is a cardiovascular disease continuum across the spectrum, starting on the left here with patients with risk factors, especially including hypertension, development of atherosclerosis, and coronary disease. And this continuum going all the way over to the right, these are mostly the patients that I tend to see. Those are the patients referred to our program with either suspected or already diagnosed heart failure. They did not get there overnight, most of these patients. And so if we think about that, what this brings to mind then is trying to intervene at the various stages of this continuum before they have to come to see someone like me in the heart failure clinic. Moreover, this disease that develops over years, or this condition, I should say, that develops over years, has a relatively silent, long period of time during which patients are asymptomatic, but the cardiovascular system is undergoing significant remodeling during this time. Oftentimes, there is an index event. This can be as simple as developing hypertension at an early age. It also can be something like a myocardial infarction. And gradually, over time, the left ventricular remodels in an adverse fashion and ends up dilating. But this process taking years to the development of symptomatic heart failure. This so-called, we sometimes call secondary damage. These other mechanisms are invoked, and importantly, these are various neurohormonal systems predominantly that are responsible for the development of a dilated ventricle and the development of symptomatic heart failure. Now, there are compensatory mechanisms that can help to try to reverse this phenomenon, and very importantly, are very powerful medications that we use in these days can augment these compensatory mechanisms and actually turn the clock back on most of these patients in this day and age. Now, I've described a process that occurs over years for the development of a patient with heart failure. In a patient with established left ventricular function, what I want to point out that on the way to an acute episode of congestion is we tend to see patients who understandably have developed their symptoms of heart failure. But also very importantly, is that these patients who have their symptoms leading to an acute, say, a hospitalization for acute heart failure, they have been developing various abnormalities, including the development of increases in left ventricular filling pressures weeks ahead of time. And so this is important, that by the time somebody's developed their symptoms, a lot of this process has already taken place, whether you're talking about new onset or somebody with established disease. So therefore, it's important to be thinking earlier and earlier stages in terms of having our yellow flags up for, is this someone who's on the road to developing symptomatic heart failure. So initial evaluation of patients with heart failure, like almost everything in medicine, it begins with a careful history and physical examination, especially vital signs, looking for signs of volume overloaded. In those patients who develop heart failure seemingly de novo, where maybe a genetic predisposition, we take a careful family history to see if they've had a history of family history of heart failure, or a family history of early sudden cardiac death, which could be indicative of structural heart disease or cardiomyopathy. In terms of laboratory and ECG testing, we get the usual general testing. In addition, obviously, a 12-lead ECG that helps to guide in terms of our thoughts in terms of etiology. And then we look for additional laboratory testing, especially the addition of BNP to help guide with the question, is this heart failure? So that initial assessment then usually includes the laboratory testing for natriuretic peptides, either BNP or NT-proBNP. Some institutions are different with regard to which one they use. And also the echocardiogram. We get a lot of information from echocardiography. Certainly the ejection fraction and separation into a reduced ejection fraction or preserved ejection fraction is very important. But we look at a lot of other information on that echocardiogram. We're looking at chamber sizes. We're looking at including the atria, left and right atria. We're looking at wall thicknesses. We're looking at valvular function. We can estimate cardiac filling pressures, and even on both the right side and the left side. So a very important tool in our guiding both the assessment as well as then guiding our treatments for it. So when we have a confirmation of the diagnosis of heart failure, we classify those generally as those patients with an ejection fraction cutoff of 40%. So the ejection fraction is equal to or less than 40%. We call those patients now HFrEF, or reduced ejection fraction heart failure. If it's higher than 50%, 50% or higher, I should say, we refer to that as preserved ejection fraction heart failure. Now, the patients in the middle represent a little bit of a quandary. I don't have time to go into some of the details of this quandary, but suffice it to say, there can be some of these patients behave more like reduced ejection fraction heart failure patients, and some of them behave more like the preserved ejection heart failure patients. But it's helpful to remember these cutoffs of especially importantly ejection fraction of 40% or less than, because we have our most powerful therapies are in those patients with reduced ejection fraction. So what do we do for patients who are at risk for heart failure? Well, those patients, and most of them will have had heart failure, hypertension, as I mentioned, optimal control of blood pressure. Those patients who have diabetes, SGLT2 inhibitors have now come into play with almost all of our patients with heart failure. The problem is, in the absence of a patient actually with heart failure, it's hard to say that we can actually prevent its development. But certainly in a patient with diabetes, please think about getting these agents on board earlier rather than later, because these agents we know are so important in the treatment of virtually all patients with heart failure. Those patients who have cardiovascular disease, CVD, we're obviously going to manage their cardiovascular disease, whether it is with procedures or medications. Those exposures to cardiotoxic agents, especially various chemotherapeutic agents, we now work closely with our oncology colleagues, and we actually now have developed a cardio-oncology program here at Metro that we have close collaboration here in the heart failure program, as well as with the oncology. I mentioned the first degree relatives, and then patients at risk, at risk for heart failure. So in terms of treatment of symptomatic heart failure, step one is establishing what the ejection fraction is. And in those patients that have reduced ejection fractions, 40% or less, we're talking about 4 therapies in virtually all patients now. We're talking about, so most people are familiar with ACEs or ARBs and ARBs or beta blockers. If we speak more generally, I like to speak of blockers of the renin-angiotensin system. So that would include either an ACE inhibitor, an angiotensin receptor blocker, or a combination, what we call ARNIs, or angiotensin receptor neprilysin inhibitor, that being sacubitril/valsartan. So one of those is going to be very important in the patients with reduced ejection fraction. A beta blocker, a mineralocorticoid receptor antagonist, i.e. spironolactone or eplerenone are the 2 most common that we use, and an SGLT2 inhibitor. Notice that those 4 building blocks of all patients, I actually did not include diuretics. Why is that? Because not all patients with reduced ejection fractions have congestion. Now, if they have volume overload and congestion, yes, we'll add diuretics. Diuretics have never been shown to actually improve outcomes, believe it or not, in patients with heart failure. We use them a lot, but they don't decrease mortality, and they certainly help symptoms, though. So that's why on our guidelines now, these are taken from the American Heart Association most recent guidelines, we say diuretics as needed, but these 4 building blocks of therapy, treatment of symptomatic heart failure. So the step 2 is the ejection fraction. We put the patients on these 4 therapies, and then see whether or not have they improved their ejection fraction. If so, have they normalized? We have plenty of those patients in this day and age. Have they improved but not normalized their ejection fraction? Well, that determines then the next steps. So as a step 3 then, those patients with a continued lower ejection fraction, what are we talking about? Well, in African-American patients, we have very good prospective data showing that the addition of isosorbide dinitrate and hydralazine improves outcomes, both hospitalizations and mortality, specifically in African-American patients. Not, by the way, nearly as powerfully in non-African Americans. If the patients have a wide QRS complex, these are all things that we consider, and usually these patients are with us in the heart failure programs at this point. So I mentioned hydralazine and nitrates in African American patients. If their ejection fraction continues to be low, and about 35% there is a cutoff in most patients, that's a patient that needs an internal cardiodefibrillator or ICD. If they have a wide QRS, they might require or benefit from a biventricular device as well. Again, these are the more advanced patients that we're going to be seeing in our heart failure program and in cardiology clinics in general. So when should people think about referring to an advanced heart failure program? Well, the American Heart Association has developed this acronym, I need help. I'm not going to go through every step here. Some of these are kind of obvious, I standing for inotropes. But I would point out that the N here for NYHA functional classification, and we actually have here at Metro this on our as a potential reason for referral to heart failure. And that is, do patients have continued symptoms, NYHA functional class 3 or 4 symptoms with either lighter, more sort of moderate degrees of exertion or at rest heart failure symptoms. If they have evidence of end organ dysfunction, especially renal involvement, we're worried about those patients. I mentioned the patients who are at risk that have a low ejection fraction, that needing some help with those patients. If they've been hospitalized, that is also important. Okay, so basically in those patients with reduced ejection fraction, we're talking about a 4-drug regimen for all of these patients. And I mentioned what these were then in the previous slide. If the ejection fraction remains low in about a 3 to 6 month period of time, these drugs do work magically in patients with low ejection fraction. By the way, it's taken decades of a lot of research to try to understand why and the fact that they do, but indeed they are very effective in most patients. So if the ejection fraction still remains low after time, so in that period of time, it takes 3 to 6 months for the full improvement to be seen to these medications. If they're African Americans, we're going to be likely adding nitrates and hydralazine. They may need a defibrillator and potentially biventricular pacing. In those patients with ejection fraction over 40%, we often tell patients we're going to declare a victory. Now, it may not have normalized, but often we can double or triple ejection fraction, and it is very much a sign of success. Successes that 20 or 30 years ago we just rarely saw, now we usually see. In addition to pharmacologic approaches, it is important that we have a lot of other things that we're doing often at the same time. Extensive education, like any chronic disease, patients need to understand the reasons why on earth do we need 4 drugs? Sometimes if it's de novo or new onset of heart failure, all of a sudden they're on at least 4 medications for their heart failure. Attention to dosing. Looking what we do volume assessments every time we see a heart failure patient, and looking at vital signs, controlling blood pressure. Often our heart failure patients will have, quote, cured their hypertension, as well as persistent tachycardia. That's not a good sign, but is a potential target for treatment. These therapies, these combination therapies, are extremely powerful. Shown in this slide, the addition of cumulative therapies with a reduction of more than 80% with these cumulative patients. There's a few things in medicine where we can show an over 80% reduction in mortality. Now, just a couple of words about some of the racial differences. I alluded to that in terms of some of the risk as well as some of the treatment. It turns out some of our therapies do affect minorities differently. So for instance, when you look at the effects of an ACE inhibitor, these effects were most prominently seen in European Americans Whereas in African Americans, ACE inhibitors weren't nearly as powerful in terms of the reductions of hospitalizations and mortality. So we do see differences treatment by race. The therapies that improve outcomes in patients with heart failure, there are a lot of them. I mentioned, I at least alluded to most of these medications, but there are also various devices, procedures, and these all have been shown to benefit patients with heart failure. So it's complicated. And so by the time the patients develop left ventricular dysfunction, have been hospitalized, generally we like to be seeing these patients because these are things that we do every day. After this talk, I'm leaving to go to my heart failure clinic this afternoon. So we see these patients every day. We have a lot of experience with the patients and the therapies. But hopefully that you'll see that there's a lot of things that you all can do up front. So I said what to know, what to do. First of all, that heart failure is common, carries a poor prognosis. It's characterized by activation of multiple pathways. These are these deleterious remodeling pathways. Most of these are neurohormonal, the angiotensin, renin-angiotensin system, sympathetic nervous system. And evidence-based medicine supports the use of multiple approaches, and this is why these multiple therapies. So what to do for patients at risk of developing heart failure? Aggressive control of risk factors, especially hypertension, obesity, and diabetes. Monitor for comorbidities, renal dysfunction, obstructive sleep apnea, rhythm abnormalities, lots of PVCs or runs of atrial or of course ventricular arrhythmias. For those patients with lower ejection fractions, 4-drug regimen in all, and for heart failure patients with the reduced ejection fraction, it turns out that dosing is important. I do not have time to go through all the target doses of all of our therapies, but just to point out that we're talking about relatively high doses. So if you're talking about lisinopril or enalapril, generally 20 to 40 milligrams a day, 24 hours a day. If you're talking about metoprolol succinate, gold dose of 200, carvedilol at least 25 milligrams a day. These target doses, it turns out, are important. Now, how about patients who has either improved or their ejection fraction was never low? Well, control of the comorbidities, control of hypertension, most important. The use of SGLT2 inhibitors in all those patients with diabetes, and actually most of heart failure patients who have, even with preserved ejection fraction, without diabetes. A mineralocorticoid receptor antagonist, i.e. spironolactone or eplerenone in most patients. Careful, hyperkalemia is a real phenomenon. We see it in quite a number of patients. Turns out in those patients whose EF ejection fraction never made it low, but who have had high ejection fractions, beta blockers, not so good an idea. And we now are increasingly actually taking beta blockers off of some of those patients. Those patients who have ejection fractions in mid-range, as I mentioned, some are more like the reduced and some are more like the reserved patients. Again, more comorbidities, hypertension. Who remains at risk? Those patients who remain symptomatic, ejection fraction low, if the natriuretic peptides remain high, those patients who are only on low doses of beta blockers and or ACE inhibitors, ARBs. Comorbidities are still not recognized or adequately treated. We look at anemia in a lot of patients in the heart failure clinic, and those patients that are hospitalized. Since it's drawing nigh, I think I'll end on this slide, and that is going back to this slide about the cardiovascular disease continuum, and reminding everybody that aggressive treatment on this side can prevent a lot of patients from going to these later stages. And that's where our primary care colleagues can be very, very helpful. And then co-management of those patients with heart failure. Thank you very much. I'll turn it back to Amy for her moderating of the rest of the session.
Thank you so much for an excellent discussion. I want to remind everybody, if you have questions, please use the Q&A function that's available on Zoom, and we'd be happy to answer questions. If you've already put your question in the chat, I do have them listed for us. And in addition, we will have the slides available on the website probably tomorrow or Friday. So if you're hoping for these wonderful charts or diagrams, you'll have access to those. So to get started, I'd like to start with our first question, which is, how important is bendopnea in the symptomatology of heart failure? And for those who might not be familiar, bendopnea is shortness of breath within 30 seconds of bending over at the waist.
Yes, this symptom just sort of came onto the radar screen about 20 years ago or so. And we didn't have a lot of, we knew that some patients have bendopnea, and until more recently, we didn't really understand the mechanisms. We now think we have a pretty good understanding of the mechanisms of bendopnea. So what is somebody doing when they bend over? And that is they're increasing intra-abdominal pressure. Well, why is that important? It's important that because one of the major reservoir for fluid in all of our bodies is the mesenteric blood vessels. And in a patient with heart failure, these mechanisms that are normally very tightly regulated, they have less of a margin for regulation here. And so with an increase in abdominal pressure, what they do is they translocate the fluid that was in the mesenteric vessels to the thoracic cavity, increase filling pressures, and then and that's what drives them as the major driver of symptoms of dyspnea, either at rest or with exertion.
Thank you. Moving on to a question about genetic risk factors. What do you suggest for those who have predisposition from family for these diseases and risk factors? What should we be doing to lower their risk of heart failure?
Let me see if I understand the question. So you're not talking about the genetics of heart failure per se, but the genetics of the risk factors.
I think if they have genes or genetic factors that predispose them to heart failure is the question.
Okay, let me answer that in two parts then. So there are patients who are first-degree relatives of patients with identified genetic causes of heart failure, and in those patients, we screen at least the first-degree relatives with genetic testing. We work in close concert with our genetic colleagues. And they, in this day and age where it's more accessible to get the full genetic profiles, see whether they have presence or absence. Unfortunately, a lot of these patients have undetermined VUS, variants of unknown significance. So it doesn't give us a specific etiology. Now, those patients who have genetics for the development of risk factors, this is not unlike the treating risk factors for preventing downstream cardiovascular events, whether you're talking about stroke or development of myocardial infarction, or development of heart failure. Do we screen all those? I mean, we wouldn't be doing all that screening. We probably wouldn't recommend, in this day and age, wouldn't say that genetic screening is necessarily in order to prevent their risk of heart failure, but somebody who has a genetic predisposition to, say, the development of hypertension, certainly that should be looked at, and at earlier ages, making sure that those, especially those family members, that they know what their blood pressures are and risk for developing hypertension, diabetes, at least.
Thank you. We have many questions about medications, I think, as expected. I'd like to start with a question that's come up a couple of times. For the 4 medications that are a part of our goal-directed medical therapy, do you recommend starting all of them at one time or ramping up one and then starting another? How would you handle that from a strategy standpoint?
It depends a little bit on whether we're talking about a hospitalized patient or whether we're talking about the patients that we see in the outpatient clinic. And we see them in both situations. I can tell you that we used to think, sort of like we used to think in hypertension, starting one drug and making sure you get all the benefit there before going on to another. As that no longer applies to hypertension, it no longer applies to heart failure. So we studied the effects of beta blockers in patients who were already on an ACE inhibitor. And we used to say, okay, let's start the ACE inhibitor, see what happens, and then start a beta blocker. Here's the problem with that mentality. Patients develop benefits or experience benefits from beta blockers within literally just a few weeks of starting a beta blocker. We don't want to expose patients to that risk of either hospitalization or dying by withholding a beta blocker. So generally, we're talking about simultaneous therapies. So at least simultaneous therapies with 3 of those. A RAS inhibitor, in other words, an ACE inhibitor, ARB, or sacubitril valsartan, a beta blocker, and an SGLT2 inhibitor. I would put a spironolactone after those. The main reason is that we're looking for potential complications of hyperkalemia. It's fairly common. And so I would want to know what their baseline lab is on those therapies before adding the spironolactone and monitoring carefully for the development of hyperkalemia or worsening renal function. So the bottom line question, answer to your question is that we're talking about simultaneously. Yes, having at least 3 of these on board and potentially the 3rd on board shortly thereafter. Sorry, the 4th on board shortly thereafter.
Thank you. Do you ever use isosorbide hydralazine in non-African American patients as a trial if they haven't responded to the other therapies?
Yes, so it's interesting that the first trial with nitrates and hydralazine was a VA trial in both Caucasians and African Americans and showed a benefit. It turns out, and this wasn't discovered until years afterwards, that the patients who benefited from that therapy were the African Americans. That was a retrospective analysis, and Caucasians did not benefit in that study. So we do not use it as 1, 2, 3, or 4th line therapy in non-African Americans. Now, I get asked this question a lot about Hispanics. What do we know about Hispanics? I've asked some of my colleagues who know a lot about the racial disparities about exactly that issue. We basically do not know about benefits of these therapies. I can tell you that we have increasingly used them in Hispanics. And at least anecdotally, it helps for not only blood pressure control, but seem to help for symptom control as well. But that's how it sorts out. The 2 things to watch for, by the way, in patients on these therapies, we still only have a 3 times a day therapy with hydralazine. There's no long-acting preparation that's available. Getting it twice a day is not effective. At least it's not effective as 3 times a day, and that can be a large lift in some patients. And then the other degree of care is, of course, that patients cannot be on a PDE inhibitor. So males have to give up their Viagra or not use Viagra or other PDE inhibitors who are on that therapy.
Thank you. Just a little change of course, and we are running short on time. If we don't get to everyone's questions, we will try to make answers available on the website. A question about reversible causes encountered in clinical practice, frequent PVCs, other arrhythmias that might predispose to heart failure. What should we be doing with those in sort of the outpatient clinical setting?
Um, it turns out that yes, PVCs alone can induce a cardiomyopathy. Um, you have to have a lot of PVCs, like more than 40% of your heartbeats being PVCs, in order for it to develop it. But we do see that. What is more common is other arrhythmias with rapid ventricular responses, especially atrial fibrillation, atrial flutter, as a cause of a cardiomyopathy. Fortunately, we work closely now with our electrophysiological colleagues to try to cure those rhythm problems. And so those we call tachycardia-induced cardiomyopathies is one of the reversible causes of cardiomyopathy. And so we will get patients with an ejection fraction of 20%. You treat or cure their atrial fibrillation and their ejection fraction goes up to 55%. And we may not have to do this full gamut of quadruple heart failure therapy at high doses if we find a reversible cause of their cardiomyopathy. I didn't mention it, alcoholic cardiomyopathy, not terribly common, but is another potentially reversible cause of cardiomyopathy that we do see, you will see. And if you get these patients to stop drinking, which interestingly, our anecdotal success is pretty good when you develop a cardiomyopathy of getting them to stop alcohol, it can reverse that cardiomyopathy.
So one final question on follow-up screenings. How often do you recommend echoes in the patients you're following for heart failure? And how often should we be checking BNP levels or only when they're symptomatic?
Wow, terrific questions. So we need that ejection fraction at baseline. And then assuming it's in a patient with reduced ejection fraction, we want to see 3 to 6 months later, has that ejection fraction risen above, especially that important over 35%, because that means if they haven't, that buys a ticket to a cardio-defibrillator. Plus it's helped prognostically. Somebody that improves their ejection fraction to normal, 50% or higher, that is good prognostically, as opposed to somebody who's had our terrific quadruple therapies at good doses and hasn't. So that's 2 baseline echoes. Let's say a patient, typical patient, comes with low ejection fraction, give them aggressive therapy. 3 to 6 months later, their ejection fraction is now 45%. Our guidelines actually now recommend against getting routine echocardiograms in those patients, which is sometimes a little hard sell to patients. Well, what is my ejection fraction now? Unless patients have an intervening clinical event, we do not get routine echocardiograms in those patients. In terms of natriuretic peptides, we use that certainly to help us diagnose heart failure. And what we like to do is we like to get those, if the patient's hospitalized, we like to get a pre-discharge, a natriuretic peptide level, because that pre-discharge can help us prognostically. And then in the chronic stable heart failure patients, around the time that we're getting that follow-up echocardiogram, we'll get another BNP to see where their BNP is. If it's still very high, that is a patient at risk. But if indeed we've been successful on lowering that, then we can reassure the patient and ourselves that the patient has benefited from our therapies.
Thank you so much, Dr. Dunlap, for this great discussion today. I want to pass it off to Sherry quickly to wrap up, as I know we're running a bit behind. Thank you, everybody, for some wonderful questions. We will try to address those as well.
Thank you, Dr. Zack, for moderating, and Dr. Dunlap, wonderful talk. Thank you so much for joining us. Just a reminder, if you want CME and you haven't registered, please register so we can send you the CME evaluation, and you can do that through the QR code or a URL in the chat. We do want to hear from you. There'll be a survey that we send out right after this that's separate from the CME evaluation survey, which you'll receive next week. And this survey is really just to help us improve our webinars in the future. And then we do already have our webinar, next webinar scheduled for Wednesday, February 28th. And we are going to be talking about metabolic dysfunction associated steatotic liver disease, formerly known as NAFLD, non-alcoholic fatty liver disease. And our speaker is Dr. Kante from The Ohio State University. So I'm really excited and hope many of you can join us at that time. And thank you so much for coming. Feel free to visit our website if you want to see more about the resources we have, or follow us on social media. So thank you all for coming today. And thank you again, Dr. Dunlap, for joining with us.